Well, it's a huge concern for we as clinicians, and it's a huge concern for we as at EHA in terms of thinking about this, not just in the UK, but right across Europe, the disparity in how these tests are available. In the UK right now, you can get a ibrutinib frontline if you have a 17p deletion or a p53 mutation. More and more centres have access to the mutation. The fish has been around for a long time. And what we're seeing is once people were using the test, more people were seeking out to be able to do it, and at least that's becoming available. The importance of the IGVH mutational status is that if you are unmutated, you clearly benefit from ibrutinib over FCR. The question's out about whether you're mutated or not. Now, if you're mutated, there's probably close to a 60% chance you could be cured with FCR, so it's certainly still an option for that subgroup of patients. But of course, first you've got to be able to determine whether a patient is mutated or not. Most of the big cancer centres have access to that kind of assay. Getting that assay, what we call approved, to be able to be tested in the laboratory, and making it a test that is available to clinicians is where we are with the challenge right now. There are very standardized techniques which are available, of which there are quality control mechanisms in place. There's an organization called ERIC, the European Research Initiative in CLL, which has set up a quality assurance program to look at this and assess whether a lab can do it. The issue right now is, of course, if you aren't able to use it, why should a hospital pay for the test? What we're hoping for is that when we are able to use it, there's not then a delay in people having access to the test. And there's this whole question of what we call, not just for this setting, but what we call companion diagnostics. It's appearing more and more in cancer. You can only get drug X if you have mutation Y. And if you can't be tested for the mutation, you can't get the drug. So you could think it's a kind of backdoor way of stopping access, and that's what we want to be thinking about how we overcome. If NICE does come up with an appraisal that looks at offering a subset of the patients based on mutational status, then I'd say that it's absolutely the evidence we would need to go to our laboratories to say, now you have to provide this test for us, and we have to be able to provide it, if not at least locally, then regionally, to mean that every patient with CLL has access to that information.